Thanks for the chance to present the Moving Forward with Confidence project. I'd like to start by acknowledging some really key people involved in this project. First, Emma Sayers, who designed the project, and the oncology nurses who were really critical to the implementation of this project, and there's at least one of them in this room at the moment. And also Professor Patsy Yates and Kate Hunt from Queensland University of Technology, who are evaluators for the project. The North Eastern Melbourne Integrated Cancer Service, or NEMICS, we're a cancer clinical network and we work to improve cancer services, and we piloted a supported self-management intervention with survivors who'd completed active treatment for cancer. And the project, as I said, Queensland University of Technology was a partner, but the Cancer Council Victoria Helpline Service were also a critical partner for this project, as was Austin Health, Eastern Health and Northern Health. When I talk about supported self-management, I'm really referring to interactions that really actively engage survivors in problem definition and problem solving, and that really seek to support survivors' self-efficacy. And I think there's a number of drivers for this approach. I guess we know we've got limited healthcare resources and varied readiness to engage with survivorship interventions, so increasingly people will need to know how to get assistance for their specific problems when they need that assistance. Cancer care consumers are seeking to be more active in decision making about their health, and certainly there's growing evidence that supports this kind of intervention with other chronic disease populations. Macmillan Cancer Support recommends that supported self-management become a key tenet of risk-stratified survivorship care, and they conducted a review that found that self-management support interventions that included survivor-generated goals and that really looked at targeting self-efficacy were more effective than interventions that just provided information and support alone. And there is some emerging evidence suggesting that cancer is not necessarily a teachable moment, and that just providing information about health behaviour changes doesn't always predict health behaviour change, unfortunately. We aim to support survivors to self-manage their health and to optimise their well-being. To evaluate the aim, we use the Health Literacy Management Scale, or HELMS, the Health Education Impact Questionnaire, or HiQ, and subscales of the Assessment of Self-Efficacy in Managing Cancer Symptoms and Treatment Side Effects. That's a tool developed by Patsy Yates. And we embedded these in participant interviews that were completed pre-intervention and were scheduled about 6 months post-intervention. We also aim to educate health professionals to promote self-management abilities in their patients through provision of an education and mentoring program, and we included a focus on motivational interviewing strategies in that program. In terms of the actual intervention, we piloted a modified version of a survivorship care plan, once again developed by Professor Patsy Yates, and it was called My Health and Wellbeing Plan, and I've got loads of copies of that, so if anyone in the break would like a copy, just come and see me. Most participants developed their plan during an individual session with an oncology nurse at the health service, although some developed their plan over the phone with a helpline nurse. And following this, a helpline nurse provided telephone support with the plans at 1 month, 4 months and 8 months. And these follow-up calls really aimed to identify any new concerns, track progress with the concerns identified during the plan, and to support motivation for goal attainment. At each intervention point, a copy of the plan or a plan update was shared with the participant, their GP, and the helpline service and the actual referring health service. So we recruited survivors with breast, haematological and colorectal cancer, as well as survivors who attended an ambulatory oncology rehabilitation program. Due to slow recruitment, we widened recruitment to include helpline callers who were eligible for the project, and also eligible members of Cancer Council Victoria support groups. Survivors with stage 1 to 3 cancer were eligible if they'd completed treatment within the preceding 12 months, although those who had acute major mental illness or significant cognitive impairment were excluded. We encountered a number of challenges in the implementation of this project, and firstly, and fairly critically, capturing survivors at end of treatment was challenging, particularly for the colorectal and breast services. Many survivors had treatment across many services, and whilst we had good general support from doctors on some units, actually engaging doctors and other staff to flag end of treatment can be quite difficult. In contrast, survivors attending the haematology service and the rehab group were very easily identified. We recruited 64 participants and 14 later withdrew. 6 of those withdrew for health reasons. 4 of those health reasons didn't relate to cancer, and that left 50 participants in the study. The intervention was not always well targeted. Of the 43 participants who completed the post-evaluation interview, participant experience varied really markedly between those who were highly engaged and reported great benefits, almost evangelical about the project, to those who really reported minimal or very few benefits. And the project nurses were in agreement that survivorship coping was mediated more by psychosocial factors than tumour type or staging or treatment type. Although interestingly, most of the participants who highly valued this intervention had breast cancer, and I'm smiling at the breast nurse who did a lot of this work as I say that. Most of the participants developed wellbeing goals and reported achieving most of their goals. 28 participants established and maintained exercise routines, and some made major lifestyle changes that they attributed to the project. One lady commenced exercising for the first time in her life and said she lacked confidence with exercise prior to the project, and she lost 15 kilos. And one fairly remarkable gentleman who had a history of problem drinking stopped drinking and smoking and was sort of combining running and walking 5 kilometres daily. So that was great. Statistically significant changes were evident at post-intervention for 2 out of 8 domains on the HiQ, and they were positive and active engagement in life and emotional well-being. A few participants reported minimal concerns at baseline or were really already effectively self-managing and reported that they would have made lifestyle changes without this intervention. At baseline, most participants had very high health literacy scores on the Helms measure. A score of 5 on the Helms questions indicates without any difficulty, and at baseline for 7 out of 8 domains, the scores were greater than 4 out of 5 on that measure, so they were very, very high, extremely health literate population we recruited. Only 1 of 8 domains showed statistically significant change on the Helms at post-intervention, and that was patient attitudes towards their health. Similarly, self-efficacy scores tended to be quite high at baseline, and no statistically significant changes were found post-intervention. At post-intervention, 69.8% reported that they had received education about the impact of cancer, cancer treatments and the likelihood of recurrence through this health and wellbeing plan, although some indicated that they had already received this information prior to the project and didn't require it at this time point. 86% believed that the intervention had impacted their ability to manage their health, and 84% reported that they developed goals or strategies while creating their plan, and 86% indicated that these goals and strategies assisted them to take up new activities or return to activities that are important to them. 79% indicated that they developed new knowledge, skills or strengths while developing the plan. Some caution does need to be used in interpreting these results because the participants who disengaged from the project unfortunately didn't complete the final interview despite desperate attempts from the project officer to get their view, so that there's probably some skew in this feedback. There were varied preferences for the timing of the intervention. Some said they would have preferred to have had it a little earlier, right at the end of treatment, although one woman remarked, "Quite a few months had passed after my treatment and I was open to things a lot more than I was earlier on, and things came up that I would not have expected to come up." Delivery of the initial health and wellbeing plan took at least an hour and a half on average, and helpline follow-up calls took between 45 minutes to an hour, as you can imagine placing considerable strain on nursing resources across sites. The health service nurses sometimes had difficulty prioritising survivorship needs alongside the very many acute care tasks that they were expected to perform. Scheduling follow-up calls to meet participant needs was also quite time-consuming. 81% of participants provided positive feedback about the helpline follow-up provided, and some provided extremely positive feedback about this. There were some participants who disengaged from follow-up calls, and once again they didn't participate in the post-intervention interview, which I think skews this data a little. But 70% thought that the helpline calls had helped to keep them motivated to work on their wellbeing. Regardless of the response to the intervention, more than half of the participants did not require 3 calls over the 8 months. There were some participants who made few lifestyle changes but reported highly valuing the support provided at follow-up, and this especially applied to people who presented with anxiety and depression. And I think this suggests that people with anxiety and depression should not be excluded from this kind of intervention. Despite resource issues, the helpline nurses adapted quickly to providing self-management support interventions, and I think the project suggests that cancer NGOs could be well placed to provide this kind of support if they have the resources to do so. So just very quickly, we only had 35% of participants who asked to be linked to community services, and the only issue that arose, there were 2 participants who had delayed access to rehab, and they were both people who presented with fatigue. In terms of linkages with GPs, 20 out of 22 GPs indicated on a survey that the health and wellbeing plan would be useful to them in their practice, but only 6 actually mentioned the plan with the survivor. So despite the challenges we encountered, we identified, I'm getting the wind up so I'll make this quick, a few opportunities for survivorship service provision. And I guess firstly there are some units where it's quite easy to identify survivors, and they're listed on the top left there. And I think it's important, and Kate referred to this before, hospital-based survivorship initiatives are probably going to be more effective if they adopt models that appeal to cancer specialists. So I think it's important to think about that with your model. The other major area for development this project really identified was the need to build capacity with improving care coordination with community health and rehab services. And we know that there's services like smoking cessation programs, health coaching, exercise programs, life after cancer programs, and things like that, as well as many NGO programs that are really relevant for this group of people. So I guess in summary, while most participants who engaged benefit a lot from this intervention, it definitely needed to be better targeted, and we need more research to tell us who benefits most from this kind of assistance.